Started, everyone. So welcome, welcome. I know people have been in the chat saying good morning and welcome. It's always good to see folks from ARPA coming on. People are still coming in. My name is Dr. Kyla Holmes, and I am a past president of ARPA and also the current chair of the Professional Development Committee. So we're just happy to be able to kind of have everyone here and to be hosting this virtual fall conference, our fall 2021 conference. So thank you everybody for being here today and supporting what we're doing and coming together and learning. So as you can even see with Dr. Trivedi's slide here, our theme is giving and receiving. So if you all notice in the brochure, a lot of what we're talking about here today has to do with either kind of giving back to our community, giving back to those that we serve, and then us also receiving. So obviously as psychologists, we pour into other people by giving, but then we also need to receive. So we're gonna definitely tomorrow be talking about self-care and other types of things where we're receiving and pouring into ourselves. But we certainly look forward to Dr. Trivedi's presentation today regarding giving and receiving. Just a few housekeeping announcements there. As you all are coming in, if you don't mind, I know we can see you all in the participant list, but if you don't mind putting your name in the chat, that's going to be our way for signing in and out. For those of you all that have been with us during previous, I see, thank you for putting your name in there. If you've been with us for previous virtual events, you know this is our way for signing in and out. Of course, we save the chat. And Eric DeRay, our wonderful executive director, he goes back through, and that's our way for making sure people were actually on during the majority, if not the entirety, really of the presentation. And that's the way that we know who to give their CE certificates to. So please, thank you for putting your name in the chat. So we're going to do that. Please kind of listen for announcements about that, because that's how we're going to keep up with everybody's attendance. So before and after breaks, before presentations, just at various points, we're going to be asking people to put your name in the chat. Okay, so I'm just spending time with that so everybody kind of hears that about putting your name in the chat. Thank you for doing that. The other thing is, if you have any questions throughout the presentation, please feel free. Our chat is going to be busy. Our chat box is going to be busy. Please be sure to put any questions in the chat box. And when Dr. Trivedi is able to respond to those questions, we'll do that. I'll keep an eye on that as well and kind of make note of any questions we see. So please put any questions and comments in the chat box for the presentations throughout today and tomorrow. Please also know, you all probably heard the announcement that this is being recorded so that we can upload to our YouTube channel. As you might know, we have a YouTube channel. Please go to that. If you are a YouTube watcher, then please go to our channel and subscribe so you can kind of see previous presentations. And then also these will be uploaded to our YouTube channel later. Okay, and for the presentation, I see most of you all are muted, but if you don't mind, just out of courtesy, so we can be sure to hear Dr. Trivedi and all of this wonderful content, if you don't mind muting yourself throughout the presentation so everything can be recorded efficiently and we can hear our presenters. Okay, thank you. Those are all of my announcements. So I'm going to turn it over to our president, Dr. Betty Everett.
Good morning, everyone. I'm glad to see folks arriving, and I miss in-person conferences, but hopefully we can communicate with each other in ways that help us feel connected during the conference. We're honored and delighted to have Dr. Trivedi with us today. She's done a lot at national level and in different states, including where she now practices in Texas, working with low income and economic marginalized populations. And this has been one of our focuses this presidential year. So we're delighted to hear from Dr. Trivedi about this. Dr. Trivedi's in practice in Houston, Texas, and got her bachelor's degree there at the university and has her doctorate from the California School of Professional Psychology. She works with low-income, economically marginalized populations. She does psychological assessment and individual therapy as her primary focus. She's worked in quite a variety of settings, so as you listen to her today, you might think about the setting where you're working, and I'm sure she will have some comments about how to help support you in taking care of these marginalized populations in your practice. Let's see. She's in the process of studying for psychopharmacology practice, and that's always exciting to see a psychologist go in that direction. So she likes meditation and yoga and spending time with her family, especially her fur baby. Shanu, is that correct, Dr. Trivedi?
It's Chinu, like chi, like cha, like chi, and then new, like brand new. But yeah, Chinu. Right. Yeah, good. You got it. You got it right, basically.
Yeah.
Yes.
All right. Welcome. I will turn it over to you, unless Dr. DeRay, Eric DeRay has anything he wants to add before we get started. Eric, you good? All right, let's get rolling. Thank you.
Good morning, Arkansas. I'm just curious, where in Arkansas are you all guys from? I'm going to look at the chat, or you can just shout out.
Little Rock.
Little Rock. Okay, Jonesboro, Fayetteville. Okay, Conway. From Little Rock, living in Conway. Okay. All right. So are these all very close to Little Rock, or are they like spread out? Tontatown. I hope Tawnytown. Okay. Hope I'm saying that right.
We have a lot of people from Northwest and Northeast Arkansas, including Central Arkansas areas. I didn't hear a lot of Southern Arkansas, but we usually have some of those folks too. So
okay. Okay, sounds great. Okay, so I'm just going to minimize the chat, and just feel free to interrupt if somebody has a question that they want to get answered right then, or you can just put it in the chat. So today, let me kind of adjust myself. I'm actually looking at some notes as we talk. Okay, maybe this way. All right, perfect. Okay, so today we, as mentioned, the title is Giving and Receiving, Working with the Low Income and Economically Marginalized. And this is an acronym from the APA. So I will be referring to this population as Liem, and it could be, it could mean those that are marginalized, or just describing that, describing an individual from that group. So it could be a group, or it could be the individual. So, okay, I know we have so many people from other wonderful places in Arkansas, but not knowing that, and I thought, okay, well, I can only put in so many skylines. So I have here, to your left, a picture of the city of Houston skyline. And then, of course, the one to the right is Little Rock. You guys probably recognize that. And these are just images I got from the internet. Did not take them myself. Okay, so let's look at the objectives. The objectives are, the first one is to identify the effects of being Liem, low income or marginalized, on an individual's health and well-being. We also want to be able to list the mental health needs of Liem individuals. We want to be able to develop ways to effectively work with these people. Recognize your own reasons for working with the Liem individuals, and reflect upon your own strengths and areas of needed growth. So at the end of the evaluation, I hope that you're able to identify your thoughts and feelings, identify 2 effects of being Liem on mental health of individuals, and be able to utilize at least 2 approaches or techniques specific to this population. Maybe it's something that you've used in other settings, but is specific to this population. And describe the differences and similarities between the Liem population and yourself. And provide one suggestion for continuing education in working with the Liem, and utilize 2 self-care activities to circumvent burnout, because it can happen. It does happen. Okay. So some terms and acronyms, as I mentioned. So we have here Liem, and again, I credit that to the APA. That's not my term. And low socioeconomic status, SES. Just maybe SES in general, low socioeconomic status. Patients, clients, individuals, populations used interchangeably. Of course, you know, mental health and mental illness. All right, so I want you just to take, I have 6 questions here. I want you to take about, let's say, 5 minutes and just answer these questions to yourself. You can put them in the chat room if you want, but you don't have to. These are really just for self-reflection. So what are some thoughts that you have about this population? What are your reasons for working with the population? What strengths do you have? What are your areas of needed growth, also known as weaknesses, but I don't like to use the word weaknesses. I'd like to use either areas of needed growth or challenges. And what would you need to be an effective provider? And your self-care currently or for the future. So just take about 5 minutes and answer these questions, and I will just kind of monitor the clock here. Oh, okay, I see somebody mentioned Cave Springs. Okay. Okay, does anybody need any more time? I know I'm probably cutting you short about a couple of minutes for the interest of time, because I see some comments in here, and so I just kind of want to touch upon those. Okay, so let's see here. Okay, so I agree, Dr. Everett. They need support and they deserve good services, just as we would expect for ourselves. And I see here. Okay, and that you hope to be open and flexible and knowledgeable of their specific needs. Now, this at the end, you said you use which model for self-care?
It's called CISA. Excuse me.
CISA. Okay, CISA. Okay.
CERT.
eCert. Okay, gotcha. Okay, all right. So moving along. Kind of minimize this. Okay, it looks like it's frozen. Sorry, looks like my screen is frozen. It's not moving past. Oh, okay. All right, there we go. It was frozen for a second. So referring to these questions, perceptions, motivations, and self-awareness. So, some things to keep in mind is, do you have any biases? Are you comfortable working with this population? Are your reasons altruistic or not? Do you have any contributing personal life experiences that motivate you to work with this population? Do you have multicultural experience? What do you need to be an effective provider? Do you know where or how to get whatever you need? And regarding self-care, thank you, Dr. Everett, for sharing your practice. Do you engage in any kind of self-care? Can be anything, it can be exercise, it can be spiritual or another support practice. Another thing to think about is, how do you handle stress? Know that in advance. Some people eat when they get stressed. Some people just they neglect their personal, self-care routine. So burnout does happen. I have gotten close to burnout. Actually, I have been at burnout level at times. And I found that two things contributed to the burnout practice with this population. Is there's a high no-show rate, and the multiple psychosocial needs and their stressors. So what I have found personally to help with burnout is to set boundaries for myself, such as having a life outside of my practice, blocking all thoughts of patients outside of my work, and just having a sense of humor. I have a sense of humor. I laugh at myself. I create a personal space here in my office that it really may not mean anything to anybody else, but it does for me, like flowers. I love flowers. So I don't think that patients particularly care if I have them or not, but today they do smell really nice. So maybe that they might enjoy that. Okay, so a little bit about myself. What brings me to working with this population? So I jumped a little ahead on the slide to the next slide. So I'm going back. So my parents are first generation immigrants from India. So technically I'm an immigrant too, and I'll explain why. So I do have memories of how they started off having lower income than they do now. And despite my Texan accent, which becomes heavier the longer I speak, so we've got 3 hours together. So I was not born in Texas. I was raised here. Feel free to prompt me to help neutralize the accent. I think it's a lot stronger than the accent. And when I think of somebody from Arkansas, their accent, I think of, Bill Clinton. So is that kind of the typical Arkansas accent? Kind of? Okay. So I was born in India, specifically Mumbai, India, which is the western part of India. And so I was a year old, specifically a year and 10 months old, when my mother and I joined my father in the States. So hence I have an American accent. So So my father, he obtained a green card in India, which is actually I don't think it happens anymore. It was a very short period. The U.S. was had a big shortage of engineers, and so they were granting green cards at that time. It was a very small window of opportunity, and so there's a pattern of my community in terms of their. And it depends on which, there are multiple Indian communities also. So it kind of depends on their personal immigration experience. But so my dad landed first in New York City and then made his way to Boston. And we lived in Boston, Medford, Massachusetts. Despite there being such a big shortage of engineers, it was very hard for him to get a job. So my dad had like 3 jobs. So here he is, low income. He's marginalized. He's being discriminated against because people are like, well, we don't know these Indian engineers. I mean, I know I know we have a shortage, but we don't know what their training is. So let's. It was not until later in the 70s, Texas had, I wouldn't say like an oil boom, but the oil boom came probably earlier, but they had such a desperate need for engineers. So they all went up to the East Coast and different areas in the East Coast, and they interviewed a lot of those people. So hence that brings us to Houston, Texas. Okay, so having experienced the financial hardship, and then also in the U.S., but then also going back to India on my summer visits, I would see even more poverty there, and more marginalization. So that has really made a big impact on me. And that's my parents' legacy to me, is their own work with marginalized people. And they continue to reach out and help out in all kinds of ways. So that's their legacy to me. So I hope to continue doing that. And my whole career has been working with this population. It has either been in education or it's been in healthcare, but now I can say that it's considerably mostly in healthcare. And I do have a practice in Houston, Texas. So some differences between myself and the Liem population that I work with is the income level, education level. My immigration history is very unique. We came because we were asked. We were granted a green card. My dad was given one in India. I mean, that, like I said, that doesn't happen anymore. And I think my mom and I probably got ours after my dad got his. But it was very different. We didn't come because of war or of crime. We came for a better opportunity. So there was some poverty back in India, but we were middle class in India. And then when we came here to the US, we started off very, very low income, probably lower middle class. Okay, so let's talk about culture. Why is it important to talk about culture and to keep talking about this? Any thoughts? See somebody in the chat. Okay. Any thoughts about that? Well, something else. Okay. Okay, we're culturally diverse and we need to understand that. Absolutely. Culture, as we already know, is a shared set of beliefs, norms, ideas, values shared by a group or groups. And it's important because it supports everything that we bring to the clinical setting. And culture is constantly in flux. There's so many changes. Cultures evolve. There's so many differences within culture as they are between cultures. So culture, particularly if Liem, is going to influence if people seek help, the type of help that they seek, their ways of coping, any social supports they may or may not have, the degree of stigma to mental illness, which we know still exists, even in the dominant culture, and meanings that they attribute to the illness. So the meanings, meaning like, you know, why do they think they have this? Does this have some particular spiritual meaning? Or are they being challenged? Or is it they feel like they're not able to get a break economically? Cultural and social factors contribute to the causation of mental illness, and this varies by disorder. We know that mental illness is a product of a complex interplay of biological, psychological, social, and cultural factors. And depending on the disorder, the role of any of these factors can be stronger or weaker. So as I asked earlier, you know, why is it important to continue talking about culture? Because culture is dynamic. It's, as I mentioned, continually changing. It's influenced by one's beliefs and environmental demands. So it's important to always have this discussion. And what do you think happens when we become complacent? Okay, I see some comments here. We need to understand the strengths that reside in the individual's specific culture. Absolutely, absolutely. We do not grow and learn. We need to understand the strengths that reside in the individual's specific culture. Absolutely. Oh, you did say that. Somebody already read that. Trying to go up. When people do not feel understood at a cultural level, it opens the door for invalidation and not connecting well. Okay, very good. Misdiagnosed, yes, yes. So, misdiagnosed, and we lose people in that process, and victim blame, yes, absolutely. Okay, looks like it's frozen again. Let's see. Okay, there we go. Cultural and societal influences on mental health. Liem culture continues. So something to think about is culture-bound syndromes. And research has not determined conclusively whether whether they're distinct from individual or from established mental health cultures, or if they're intertwined, or if they're variants of such disorders. So both the culture-bound syndromes are different ways in which both the culture and environment interact with genes to shape mental health. Cultural differences in symptom presentation includes, but is not limited to, for example, somaticization. Asian patients are more likely to report dizziness, while they may not report emotional symptoms that require further exploration. It's very important to explore the meaning attributed to illness by way of making sense of subjective experience of the illness and distress. You need to explore what are their deep-seated attitudes and beliefs of whether the illness is considered real or imagined. And also you want to reflect upon your own. You want to make sure that you don't dismiss them and say that and think, oh, I don't think that, I think this is all in her head. And so, or I think she's making this up, or that she's just being overly dramatic, or access to, you know, oh, she's just very histrionic or borderline. So, you know, what's important is that it's their experience, and we know this as psychologists. What are the okay, so the consequences of culture meaning. One thing I asked, what would be the consequence earlier if we don't stay aware? And this influences whether or not they may seek treatment, whether they feel validated or invalidated. Consequences of culture's meaning of mental health include if they're going to seek treatment, how they cope, their support system, path to treatment, and how that and the treatment outcomes. Are they going to be successful in their treatment? The consequences, as I asked earlier, of not receiving treatment. Somebody mentioned that we could misdiagnose. Yes, absolutely. Misdiagnose. There can be extreme distress, some disability, loss of work, suicidality. I mean, the list goes on. They could lose their family support, their social support, so many consequences. Their physical health can get worse. So there are some very severe consequences to this, to their not receiving treatment, and to us not being aware of what their needs are and being attuned to their needs, learning about their culture, respecting their culture. Okay, so it's important to be aware of our own culture. What are our beliefs, norms, and values? And it doesn't mean that maybe it means we're not the best fit for this individual. Is there another clinician better qualified or more knowledgeable about this population? But if you decide to take somebody on for work and working with them, if let's say you're a feminist and you're working with a very traditional family, you have to, as we know as psychologists, I'm preaching to the choir here, but we have, at that moment of time, it's not about us. We have to separate our beliefs and help them with their needs. So be very aware of your biases, any prejudices you have, and being able to balance those, being able to moderate those and contain those when you're working with the individual. You know, I oftentimes get people here in Houston ask about my background, or they ask, what's my religion? Or I often get asked this no, maybe not as much now, but I get asked often, where are you from? And I'm like, Earth? What do you mean, where am I from? So what I do is I ask them, I said, well, I have no problem answering that question. That's a personal choice. You may not want to answer that question or share that question, but first I ask them, why do they ask that question? And what does it mean to them? And sometimes just having that conversation, it glosses over the whole, my need to, or I don't have to answer that question by my putting it back on them. So, are you comfortable? What's your exposure level? Have you traveled outside of your city? Have you traveled outside of your state, United States? Introspection. Be very open to feedback. And as mentioned earlier, there might be somebody better qualified. I mean, if you are very opposed to a certain, religious or spiritual belief, and somebody's coming in to you and asking to whether they should, have an abortion or not have an abortion, or any other issue, it may be that there's somebody else may be better qualified. Implicit bias. There are implicit biases, and I consider myself, I've traveled a lot and I've lived in a lot of places, but I think there's some things that I still have some biases that I have to be aware of. Okay, so I think, are there any questions at this moment, or any comments? Okay, So let's talk about, well, before we talk about the 4 major mental health care sectors, I'm just curious, where does everybody practice? Do you practice in a clinic, private practice, university setting, a combination? Okay, I see one person here. Private practice, VA healthcare center, system, college counseling, early intervention day center.
Oh.
Okay. Is there, how many of you actually already work with the Liem population? You could just say, I do, or yes. Okay. Okay, not to put anybody on the spot, okay. Who doesn't work with the Liem population? Not putting anybody on the spot, but I did ask. Okay, thank you, Dr. Stout. Thank you. Okay, Dr. Holmes. Okay. Ah, some students. Okay. Okay. There's a lot of diversity there. Okay. Okay. So, Arkansas, okay, lots of rural populations. What is the industry there? Is it farming? Is it, what is it? Like our industry here is oil and gas, but it's also intellectual properties, healthcare, IT, Walmart, okay, agriculture, retail, transport, Tyson, okay. Well, rice, wow, a lot of farming in Northeast Arkansas, okay. So, okay, so Arkansas, is it, I've heard it's a very beautiful state. Is that everybody's experience, or are there some areas that are not? When I say beautiful, like, you know, I'm referring to farming, healthcare, Walmart. I'm referring to, like, you know, a lot of, like, it's hilly, mountainous, trees or something like that. Agriculture area isn't. Is it very flat? Is the ag area very flat? Okay, lakes, trees, beautiful Northwest, fairies, Ozarks, yeah. Yeah, it's a lot of hot springs, right? Okay. Mississippi Delta. Wow. Okay. I think I've flown through Arkansas. I was visiting my dad who was working in Tennessee. Yeah, Nashville, Memphis, Tennessee. And I should have brought it today. I do have a mug from the airport. I really do. Oh, wow. I should have brought that today. And I broke the handle. I was like, no, we got to get it fixed. I want this fixed. So, okay. All right. So, as mentioned, I do work in private practice, and I've been in private practice 100% with the Liem population. I would say 99% of the Liem population, and that's been going on for the last, I would say 5 years, 5 or 6 years for me. So previously I worked in a lot of community mental health centers, some psychiatric, nonprofit psychiatric hospitals, but a lot of community mental health centers. One college counseling center, but community mental health is primarily where I've been at. And so that would fall under specialty mental health. Okay, so the first sector, specialty mental health, this sector is solely for the provision of mental health services. So this refers to mental hospitals, residential treatment facilities, centers, psychiatric units of general hospitals. Also refers to specialized agencies and programs in the community, such as I mentioned, community mental health centers, where I actually grew, that's where I say I grew up in the profession. Day treatment programs and rehabilitation programs. We recently had a lot of RTC close for children in CPS custody. So there is a big shortage of need. There are funds there, but it's difficult work, as you know. And within this setting, services are furnished by specialized mental health professionals, such as psychologists. We have in Texas also a lot of master's health clinicians, psychiatric nurses, psychiatrists, and psychiatric social workers. Then we have the general and primary medical care. We do actually have at least two different, there are more, but the two major federally qualified healthcare centers. And they offer a comprehensive range of healthcare and includes mental health services. But there's also private practice, PCPs, nurse practitioners, internists, and pediatricians. And these are the general type of professionals who practice in a range of settings that include clinics, offices, community health centers, or the federally qualified healthcare centers, and hospitals. Then we have the human services sector, which is made up of social welfare programs, housing, transportation, employment services, criminal justice setting. I worked for a community mental health center that had contracts with the juvenile probation services and also the Harris County, which is the county which is Houston is in, their adult jail system. So as mentioned, okay, criminal justice settings, educational systems. I've also provided services in there. So we actually have, how it works is we have some community mental health centers, and they actually go into the schools and provide school-based services, and they provide home-based services as well. And I've done those as well. Okay, and let's see, charitable services. So religious institutions, charitable services. Services are delivered in a full range of settings, home, community, and institutions, as I mentioned. And then we have the voluntary support network here. And this refers to self-help groups, such as AA, CA. There's a place called Bow Center, which is a grief, helps with bereavement issues, and that would be considered another voluntary support network. So, well, it depends on their funding, so I really shouldn't say, but these are organizations dedicated to education, communication, and support. And such network services are found largely in the community, and they're typically informal. They often help patients and families increase knowledge, gain support one another so they don't feel alone, help link them to resources, decrease feelings of loneliness, and obtain referrals for formal treatment and coping as well. So I think, is it time for a break?
Yes, this might be a good time if you're
Okay.
if this is because I think we're doing 2 breaks, correct? Mhm.
2 breaks. Okay. All right.
Okay.
So we could take how long do we want to take a break for?
Maybe about 7 minutes. I don't know if that works well with the flow of your presentation. Maybe about 7 to 10 minutes or what?
Let's do 10.
10. Okay.
Okay. All right.
We can
Okay.
do that. Thanks a
Okay.
lot, Dr. Trevetti. It's a good time for a break. As
Okay.
we're taking a break, you all, when we have our breaks, I would just like thank you, Eric DeRay, for putting that up. We just want to acknowledge people who have provided sponsorship for our fall conference. So as you see there, we have Arkansas Families First, who has provided sponsorship. Thank you so much to them for doing that. And just to say a little bit about Arkansas Families First, Arkansas Families First is a multidisciplinary behavioral health care group that's in an awesome way owned by 2 of our wonderful psychologists, Dr. Adam Benton and Dr. Mary Ekdahl. And we offer a variety of health services to children, teens, families, young adults in Central Arkansas. There's a location in North Little Rock and also a location in Conway, where we provide comprehensive psychological assessments. And then we also have, I believe it's 3 psychiatrists on staff and people that provide a range of counseling and other types of services. So please get the word out about all the wonderful things that are going on at Arkansas Families First. And I am just going to put, if I can get to it, I'm going to put here we go. Okay, put the website in the chat there, just so if you all want to just get the word out. Arkansas Families First does have presence in social media on Facebook and Instagram. So if you're on Facebook or Instagram, please follow Arkansas Families First and share various posts that are made periodically. We also have Dr. Chelsea Wakefield. I know that's a familiar name to many people. She is also a gold sponsor. She is at UAMS. She has presented for us twice, and we just appreciate her for offering her expertise to our association on those occasions. She presented in Northwest Arkansas when we were meeting in person, and she is also presented virtually for us. She actually has a recording on our YouTube channel. So I think this was from last year, where she presented about her work in couples therapy. So you can see there that she has a book, The Labyrinth of Love. You guys, this is a wonderful book. This is a wonderful book. I have a copy of it myself. It is great information in there. I just go through it. I haven't read it all the way through, but the part that I've read is really, truly amazing. Honestly, if you don't even do couples therapy work yourself, I just think it's just awesome content and information. So I encourage you all to please get her book. She sent some information. So just to share some information about Dr. Chelsea Wakefield, she has been a popular and valued presenter, as I mentioned, for ARPA over the past few years. We just thank her for offering her expertise. All right. Thank you, Tisha. She said, second that great book, y'all. It really is. It really is a great book. I think it's awesome content in there just to reflect on, honestly, just personally, and just kind of see how a lot of those concepts can apply personally, but also professionally. And she is the founding director of the UAMS Couples Center. So they do have a website, the Couples Center. And when I get that pulled up, I'm going to share that in the chat, so you all can go check that out on the website and all of the upcoming workshops and information that she has available. So there, she's half-time practicing working with couples in their relationships and sexual issues. She does weekend intensives. And just as you see here, this is one of her books, but she also has 2 other books, Negotiating the Inner Peace Treaty. And then it's also another book, In Search of Aphrodite, Women, Archetypes, and Sex Therapy. And of course, this Labyrinth of Love is her latest book. So please check that out. She's a longtime educator, training clinicians in her innovative method of work and offering community workshops on how to create a meaningful, enduring relationship. So that's great information about Dr. Chelsea Wakefield. And again, as I mentioned earlier, feel free to go to so this is kind of a plug for our YouTube channel as well. Please feel free to go to our YouTube channel And she has on there a recording from last year. It's great information entitled Couples Therapy in the 21st Century, Beyond Conflict Resolution and Communication Skills. So there's very helpful information there as well. All right, so thank you again to our gold sponsors, Arkansas Families First, and then also Dr. Chelsea Wakefield, and promoting her book, The Labyrinth of Love. We have about 5 more minutes or so, maybe about 5 or 6 more minutes of the break. Okay, as we're still breaking, I just want to bring everybody's attention to what Tisha has put in the chat. Definitely ARPA has a presence on social media, on Facebook and on Twitter. So please follow us on Facebook and Twitter. All right, so on the break, this will be a great time that if you're on Facebook, Instagram, or YouTube, this will be a great time to search for us and like and follow and subscribe. And we might be about at the time to start, Dr. Trivedi. So just whenever you're ready, you can just feel free to get us back started.
Okay, sounds good. So I'm going to go back to sharing my screen.
I wonder if that could happen at the same time. Eric, do you mind unsharing that part just to make it a little easier for Dr. Trivedi to share her screen? Okay, I think it may be ready for you there.
So, okay, let me see about putting in, let's get back to screen sharing. Oops. Okay, can you guys hear me and see my screen?
Yes, we can. Looks good. Mm-hmm.
Okay, is there, for those of you that are not currently working with the Liem population, are you looking to just better understand this population, or are you looking to actually go into working with the population? Do you need any support in getting started? Okay. And there's people that, and I started out, well, I started out working part-time in private practice, and then, but again, even when I worked for somebody else, it was always with the Liem population. But you could do both. Work with Liem and non-Liem individuals. Okay, so let's take a few minutes here and think about how financing affects the mental health that the Liem population gets. Okay, Elizabeth, we'll talk a bit about the research. I do have a reference list at the end from where I get a lot of this information from, and can talk to you, share some of my own experiences on how you can connect these. I'm assuming you mean connecting Liem population to those resources. Okay. Okay, I'll answer that in just a few minutes. Expand my practice. Okay. Okay, so Patricia, limited population currently in my private practice, are you referring to the Liem population is only consists of limited population or percentage of your practice? Okay, thank you for clarifying. Okay, so anybody have any thoughts on how financing affects working with this population? Actually in the work with this population, or getting this population services? Right, reimbursement is not always great. And you're right. Transportation, yes, especially if you're in a rural area of any place, Arkansas, Texas. I mean, we're not New York City, so we don't have buses. Even Houston has transportation issues. Okay, insurance through Marketplace. Okay, that's good to know. Yeah, we also have the same thing as well, Marcella. We have a crime victims organization that pays for treatment. So you're right. There are challenges to insurance reimbursement. It is low for certain certain insurances. Another thing I find is we have what's called CHIP, Children's Health Insurance Plan. Do you guys have that in Arkansas? Okay. So I had an individual she canceled at the last minute. The marketplace is competitive and comparable. Okay. Yeah, I think it depends about the marketplace. So we have like Blue Cross Blue Shield, let's say, and that's available in the marketplace. It's an HMO. And I know that there is a group of at least 2, maybe 3 psychologists, and they were able to negotiate a higher rate of reimbursement as compared to what is the standard rate for psychologists. But that's a very rare instance. I have and better. Okay. I have tried to renegotiate rates, but I haven't had any success in that. Even with, so I get paid at a lower rate, Blue Cross Blue Shield wise, as compared to these other 3, and they're psychologists as well. And I think they were just, somebody reached out to them, and a Blue Cross Blue Shield provider rep, and maybe they were in a dire need to get more providers in, because that was around the time the marketplace was opening up. So, okay, so we have CHIP here, and CHIP, there is okay, so there's CHIP. There's a Texas Children's Health Insurance Plan also, and it has nothing to do with, that I know of Texas Children's Hospital, but it's another insurance plan, another managed care. And so they will only allow you to, they'll allow you to have the initial evaluation, but then you have to get pre-authorization, and that's what's challenging. It takes a while to get pre-authorization. It gets denied. We had the same experience with foster care Medicaid. So there is the actual reimbursement rate. There is a pre-authorization requirement, which oftentimes gets denied. And I find that very challenging. When I started off, I was doing all the billing myself. And it got to be very overwhelming. They just require so many things. They want you to fill out this long form, and there are areas in this form that I have no idea really how they pertain to the service I'm providing. So, and I do a lot of testing, psychological testing, or different types of testing, not just psychological. System oppression, yes, yes. So the goal should be that they're there to pay, but that's not necessarily true. I have my own private insurance through my practice, and it's very expensive. It's very, very expensive. And but it's a PPO. I go where I want, so they're quick to authorize. It's a Blue Cross Blue Shield, but they're quick to provide me with the services I need. Okay, so let's talk a little bit more. So, when I refer to financing, I refer to an organization or entity's funding source, which can include or exclude a person, which we know can result in disparity. So for me to have my Blue Cross Blue Shield versus somebody who has to go get the Blue Cross Blue Shield, not all Blue Cross Blue Shield plans are alike. For them who get this off of the marketplace, it is there. And I looked at, okay, if I go to the marketplace, well, I'm paying the same. Let me just get it through my practice. And I get better benefits. And that creates disparity, a lot of disparity. So some other, I can think of one particular instance. There is my massage therapist, and she works part-time. And when she was working full-time, she could not afford health insurance. And now part-time, she can better afford health insurance, because it's based on her income. And sometimes the patients I have that have Medicaid actually get better, quicker services than somebody with going through the marketplace, but a lower, lower tier cost plan. So it's important to keep in mind that sometimes when you're in the middle, where like with this massage therapist, you may have what they call too much money, but it's actually not enough. So you're still in the Liem population. And then there are organizations that rely on state funding, and they do not have enough money to service all those. And so they have a long wait list. So I recently talked to somebody at a federally qualified healthcare center, and they have, like, I want to say at least 400 on the waiting list to get psychological testing, or any kind of testing, developmental, psychological, neuropsychological. That's a big wait list. But they don't have enough providers. So now our own clinical cultural competency and bias does have an impact on whether Liem individuals get adequate services. There are not enough providers from the Liem person's own cultural group. So those of us that are left to provide this service, we need to have strong clinical cultural competency. And that involves self-awareness, clinician, know thyself. So there's a saying, doctor, heal thyself. So that just makes me, that's where I made the leap from. But clinician, know thyself, know your biases, know where you come from, know what you're lacking. And then the next thing is service delivery mindset. How do you view these individuals? Do you view them as customers versus consumers? Are you wanting to collaborate, or are you on a mission just to push your own agenda, like everybody? Whether it's a good agenda, it could it could be good, it could be, we need to eat healthy, but be careful on how you, like, if you have a particular dietary need, I myself am vegan, so I'm very careful about, if we talk about eating healthy, that we talk about it from what that means to the individual and what resources they have. They can't afford to eat the way I eat, but there are other healthy choices. And so if they want to, if they come from and we're in Texas here, so I'm sure it may be the same in Arkansas, but it's a very big barbecue state. They eat a lot of meat here. And so I work with them on how they can look for healthier ways and still hold on to their belief of, well, that's what we do. We eat meat. So, really be careful that you're not pushing your own agenda. So there's got to be collaboration. I'm not on here on a mission to promote my own personal, political, spiritual beliefs. Those particular beliefs may be the reason why I'm here working with this individual, but they're not ones that I'm going to espouse onto to the Liem population or any population. I worked at a healthcare center in community health center in 2000. I won't name the name, but we used the word consumer. I hated that word. I feel like, what that's so, it felt demeaning to me, like they're consuming something. And no, they're customers. So I've always thought of them, look, they're customers. If we don't want to be here, we don't have to be here. But if we're here, we have to treat them with respect. We are here. We're able to do our work because of them. So there are customers, or you can say clients or patients. Another term that's come out recently from the same organization that you once used the word consumer is individuals. And I really like that. So, but you know, you have to look at the culture of your organization too. I mean, if you're in a hospital setting, it's going to be patients. Most likely it's going to be patients. So, you know, I always make sure to thank them. I treat them just the same way that I treat, that I get treated. And my, what I call Cadillac Healthcare Services. So, and I say that with, you know, tongue in cheek. Okay, so see if I can scroll down to the next screen. Frozen again. I don't know if it's my computer or if it's something to do with Zoom.
Yeah, sometimes Dr. Trivedi, I think it's just sometimes having to do with Zoom. Maybe if it's so, you know, the number of people on. If
That's what
it
I was
doesn't
thinking.
unfreeze or something soon, sometimes I've had to just kind of stop sharing and reshare, and that'll kind of reset
Okay.
it somehow. I don't know.
Okay, so we know our health profession is rooted, or has been rooted, in Western medicine. Do you guys, are you, any of you familiar with Eastern medicine or traditional medicine? When I say traditional medicine, I'm referring to those that are not Eastern. It's not Eastern medicine, but it's more traditional, like maybe to, you know, the Native American population or other indigenous groups. Let's see, I got some chat here. Okay. Well, you guys are familiar. How many of you are familiar with yoga? You might know, you might know more than you realize. You might not realize where it came from. Anybody familiar with yoga? Anybody do yoga? Anybody do meditation? Okay. Okay, okay, okay. Yep. So you are probably, yes, healing practices from the African tradition. Yes. Yoga, yes, meditation. Okay. Okay, so I could share with you a little bit about, you know, my cultural background. We have, well, let me ask you this. Do you guys know what your, okay, so what is the demographics in Arkansas? Like, what cultural groups do you have? There's no cultural groups? I know there's some cultural groups there. You guys are here, so. Okay, African American, Black, white, Marshallese. Oh, Marshallese. What is Marshallese?
From the Marshall Islands.
Oh, oh, wow. And how long has that community or that group been in Arkansas?
Several years. When they had to leave the island, a significant population went to Northwest Arkansas.
Okay, okay. Hispanic.
That's correct. I wish I could remember a little bit more of the details. We had some people present not that long ago, but I believe we have the second largest Marshallese population. Somebody correct me if I'm wrong, other than the Marshall Islands, because of that. Fairly large, yeah.
Wow. Okay, I know I'm so interested in cultures. I'm going to read up on this. That's all you have to give me. I got something to do tonight after work. I am so fascinated. Okay, resettle after bomb testing there. Oh, wow. Second largest population. Are you saying second largest population as in the United States, or just in compared to the Marshall Islands? In the United States. Okay.
In
Okay,
the
wow.
world, I think.
Oh, in the world. Wow. Fascinating. Fascinating. Do you guys have an Asian population? Anybody from Asia? Anybody from Africa? Okay. Well, okay, small African community. Do you guys know where in Africa, from Africa they're from? Korean, Hispanic, okay. African. Well, I know African, but I'm talking Nigeria, okay. We have a big Nigerian community here in Houston as well. We have a big Korean community. Middle East and India, okay. Okay. So, it's very diverse here. Houston is the fourth largest city in the United States. It's 2,300,000 approximately in people in Houston. It's probably, in terms of, since I asked you about Eastern beliefs, Eastern medicine, I would say, lots of draw to the, lots of draw to the UAMS. Yes, of course, yeah. It's a stereotype we have, and it's actually quite true. So there's some truth to that stereotype about, I can say, about Indians and healthcare, Indians and engineering, computer science. Yes, lots of draw to Houston because of our medical center as well, and the teaching institutions here. So Eastern medicine, and I'm going to focus more on, I really can only really speak about India, but that is where yoga is from, and it's actually from Hinduism. And this is something that, this is another issue that comes up, I'll share with you, but cultural appropriation of yoga. So you don't see, in fact, I'm the only, for a long time, I was the only Indian yoga instructor, or of Indian descent. I'm American as well. But there's the cultural appropriation of yoga that's a problem for us. But we have our food. Our food has a lot of, we use the same spices we use. We also use medicinally. There's Ayurvedic medicine that's based in the Vedas, and the Vedas are scriptures. So in Hinduism, we don't have a particular, it's not like with Christianity, you have the Bible, right? The Bible, or for Judaism, you have the Old Testament, and for Islam, you have Quran. But we have several scriptures, several readings, but the Vedas, Ayurveda comes from that. And so the Vedas influence how we eat, what proportion of food we eat, even though we have the largest vegetarian population, but still the majority, as far as I know, the majority are not vegetarian in India. But you still want to balance your food, and because I feel like that creates an imbalance in the system, which can affect the mental health. So, so you guys probably already are familiar with a lot of our spices like turmeric, and we use tons of turmeric. We also have a lower incidence of Alzheimer's. which they think it might, as compared to other populations that don't use turmeric as much as we do. So, but there's a lot more to it, and I don't want to just reduce it down to just what I'm telling you, but there's a lot more. And so going back to what I was saying is we also want to be careful of, or let clients or patients have a space to talk about any cultural appropriation that they experience and what that's like for them, and validate their experiences. So we know health profession is rooted in Western medicine, and see, it looks like it's frozen here. Hold on one second. Okay, so the culture of Western medicine can be predated back to ancient Greece, which emphasizes disease in the human body. Human body and disease go together. And Western medicine also emphasizes the acquisition of knowledge through scientific and empirical methods, holding objectivity first most, which is so interesting because you have like these providers, us or other healthcare providers, and we are trained, or we're trained in a system that holds objectivity so important, yet we dismiss a lot of things. We have a lot of bias, or we have biases, or a lack of awareness. Western medicine, as we know, seeks to uncover universal truths about disease, and to include causation, diagnosis, and treatment. Then around 1900, something changed with Western medicine. It began to conceptualize disease as influenced by social as well as biological phenomena. It began to incorporate wider social questions of income, lifestyle, diet, employment, and family structure. Then mental health professionals can really trace their roots to Western medicine, and more particularly to two European milestones that we're familiar with. And the first being biological psychiatry in the mid 19th century, and then the advent of psychotherapy, aka talk therapy, near the end of the 19th century. The earliest forms of biological psychiatry have primed the path for more than a century of advances in pharmacological therapy or drug treatment for mental illness. We know that we all know Freud, and he started off with the psychoanalysis. That's the only form of psychotherapy we had at that time. But now we have so many more forms of psychotherapy available today, and vastly different orientations. And I'll emphasize verbal communication between patient and therapist as a basis of treatment. Now, we know not all cultures, that we have to understand that not all cultures are verbal, or the meanings they hold to words may be different. There are even some phrases that you just can't translate into English. And some people, especially if you're bilingual or multilingual, polylingual, you're going to be thinking, and those clients will be thinking in two different languages. And I had a patient in here the other day, and she was trying to look for the right word in English. And I said, well, just say it in Spanish. And so I gave her that space to kind of shift gears language-wise, cognitively. I myself speak multiple languages, and I don't think only in English. I think primarily in English. English is my strongest language, but it's not my first language. So there are many times when I'll say a sentence and it'll have some English, maybe a word or two of Spanish, because I study Spanish too, but it may also have a couple of other languages like Gujarati or Hindi. Gujarati and Hindi are Indian languages. So I have shifts, and so we have to understand that these individuals, even those from the Marshall Islands, I don't know what they speak there, but do they speak English? Is that what they speak in the Marshall Islands, or is there a different dialect of English? Different. So different English or just a different language? Different language. Okay. Well, there I go. I just made a what do I call it? I just assumed that everybody speaks English, right? So that's probably my implicit bias. Marshallese. Okay. So I've traveled a lot outside of the US, and typically people don't like us Americans as customers or just as visitors. We go in expect, well, why don't the Japanese speak English? Why should they? Why don't we have a translator? Or why don't we speak Japanese? But obviously that would be harder to do, right? But we just have these expectations. That indicate that we have these implicit biases. Okay. So let's talk about classification of disease. So an accurate diagnosis, okay, let's go back. An accurate diagnosis, we're still on the same slide, will dictate the type of treatment and supportive care, as well as shed light on prognosis and course of illness. So the diagnosis of a mental disorder is more difficult than diagnosis in other areas of medicine and health. And does anybody know why? Why is diagnosis more challenging for us mental health clinicians, for us psychologists, or students at some point to be psychologists? Why is diagnosis hard for us, or challenging? I should say it's not as clear cut, maybe. Yes, so many factors contributing to symptoms. There are layered issues. We don't have the biological markers, indicators not as clear. No. Lots of issues. But you can now get what's called genotype testing. And in terms of psychiatric medications, it can tell you cultural overlays. It can tell you what medications you would respond best to. Symptoms overlap across conditions, irritability, concentration, sleep, developmental issues. Yes, we just don't have the objective measures that you have in physical medication. In physical medication, they typically rely on a lot of blood tests or EKGs, but different types of actual tests that give you a measure or actual number. And one area that I think that this is an exception in psychology is in the area of testing. You can actually get like a number, and of course at the end it still comes down to the clinician judgment, but you are going to stay within a certain range when even expanding with your own judgment. It's frozen again. Okay, I think I'm going to have to unshare and reshare. Let's try one more time. Okay, I'm going to stop share, reshare again. Okay, let's try it again. I'm trying to see where I can, the share button. Not seeing it right now.
It's usually on the bottom.
Yeah, I don't see it.
If you hit the bottom, does it pop up?
Okay. Yeah, only when I go to pull up the participant view. Okay, so here we go. Let's see if we can do this again. Okay. Can you guys see my screen? Can you see the PowerPoint?
Yes, we can see the PowerPoint.
Okay. Okay, great. Thank you. Many tests are not standardized on a diverse population. This is true. This is true. So I had a client, a patient, and I was doing, she was trying to get disability, and I was doing a disability evaluation, and one of the requirements was that she take a, well, for this particular disability was the MMPI. And this was an African American lower middle class individual, and she scored higher on certain scales of indicating, like, you know, some histrionic or maybe malingering behaviors or traits. And I had to really come out and defend her, or defend the fact that, you know, look, this is something that we do, but it's not necessarily, this does not mean that she's malingering or that she's histrionic. This is how she expresses herself. And so these are some of the things that she believes in. And some of the questions involved, they were really tapping in on psychosis, but she answered them positively. You know, there are certain things that she believes in, and those were consistent with her spiritual beliefs, her cultural beliefs. So I had a hard time defending. I mean, I was able to defend her, but they presented with a challenge. But you're right. Many tests are not standardized on a diverse population. I think somebody said something about sleep developmental issues. Okay. So, okay, let me try to get back to my slide here. Now, is this your first time doing national conference by Zoom?
No, we started this in probably April or so of 2020. So we've done.
Okay.
Yeah, but I have had this. I don't always have this kind of problem with PowerPoint on Zoom, but I have the last couple of times. So I don't know exactly. I haven't figured out exactly what makes it freeze like this.
Okay.
Yeah.
Well, it's just it's different. I'm used to doing in person, but this is this is definitely a learning curve for me.
Right.
But yeah. Okay. So all right. Okay, so let's talk about the effects of low SES on mental health. Oh, wow. Okay, a little pop up here. So these are the challenges I'm talking about. Oh, wow. You don't need to see all that. Okay. All right. So effects of low SES on mental health. So we know, or we may know, I'm sure we all know, that regarding general mental health, Liem patients tend to have worse self-reported health, lower life expectancy, and this bar is here. Oh, okay. So somebody said schizophrenia is another disorder misdiagnosed with African Americans. So, Patricia, can you tell me, has this been your personal experience as a clinician? I mean, I know it is in terms of the research, but have you had any personal experience in seeing this misdiagnosed? Or can you elaborate on that? Okay, we'll give her a chance to respond. Okay, so we're okay based on research. Okay, but not your personal experience. Okay, so okay, so we do know that Liem patients tend to have worse self-reported health, lower life expectancy. They have more chronic conditions. They're misdiagnosed, as Patricia pointed out, as we've actually a couple other people pointed out. In addition, providers may be more likely to view low SES Liem patients as unintelligent, dependent, irresponsible, irrational, and treatment non-compliant. I have a problem with the word non-compliance. Does anybody have a problem with that word? Non-compliance. This patient is non-compliant with treatment. Yes. I would prefer something like patient disagrees or has, yes, they put blame on the patient, deflects responsibility from the provider. And it's assuming, yes, same word as the word resistant. I don't like that word either. It's assuming that they need to comply. Almost like that big brother colonial type attitude that we still have from years ago. So, so going back to the 2 questions I asked you at the start of today, you know, why I had you reflect upon the earlier question regarding your perceptions of Liem patients. Because harmful perceptions such as the ones I shared they can impact provider clinical decisions with delays of diagnosis testing, misdiagnosis, as we've already mentioned multiple times, prescribing more generic medications when a name brand would be more effective, and avoiding referrals to specialty care. On the other hand, there are also those providers that tailor the treatment options, that tailor these options to a patient's SES will improve treatment protocols or treatment participation, and thereby improve health outcomes. And of course, as mentioned earlier, there's the chronic issue of low reimbursement rates that just deter some providers from treating those of the lower SES levels. So, okay. Somebody asked earlier in the chat how to better work with these individuals. I think you also, maybe you meant like engagement. I believe you said something about engagement. So one of the ways first is to do what we've been doing, talk about culture, talk about the effects of low SES on mental health. And when we talk about the effects of being Liem on mental health, there is a study, this is not a new topic. It's been written about as early as 1963. There's a 1963 study by Langner and Michael. And this was based in New York. Actually, I want to say maybe the Bronx or one of the boroughs. And it's been written around since then. There's also, and this is also on my reference list, Knifton and Ingalls discuss how poverty and mental illness are interrelated, in that poverty causes mental health problems and mental health problems lead to poverty. This correlation is likely something you've already heard of or been aware of, but it's still important to be aware and always review and reflect, because it's important for us to not contribute to the marginalization of the SES patients, low SES patients. And disparities in mental health emerges early in life and they become more pronounced in childhood. So question going back to how can we better work with this population or engage this population or start working with this population? One way is to educate, psychoeducation, and start early on, making sure that there are that the services are available in early childhood. So if you can take on 1 or 2 early childhood cases, or any type of childhood cases, doesn't have to be early childhood. We also have, another way is to be part of a group, a community group that goes out and provides education to other healthcare providers. We have a organization here in Houston called Doctors for Change. And I'm a member. I'm sad to say I've not been active, but Doctors for Change, one of the things they go out, and this is something you guys can do, and they just do pro bono talks. They go out to the community and they have people talk about different issues or educate different providers on how to work with these individuals. The talk that I went through, we had a person who had experienced sex trafficking and had severe mental health issues, goes to for several years to one of the federally qualified healthcare centers and gets treatment from there. But she came out and she talked about her experiences, and then how valuable the community mental health center was for her, or the FQIC, which actually gives all of the services. They give primary care, Wales Women's Care, children's care. They have pharmacies. They do tests. They do run lab tests. So they do provide a lot of different services, psychiatric care. So that's an important thing, is to look into your community, find out what the needs are. Are there organizations? Maybe you can join these organizations. You can start young. There's so many different ways that you can actually go in and start working with this population. To better work with this population, have that dialogue. Ask them what it means. Be careful not to misdiagnose. Look at the cultural specific syndromes. The DSM is a good resource. It's not the most exhaustive list of culture-bound syndromes, but it's one area to start with. Okay, so primary causes of mental health inequalities, we know, stem from access to economic, social, and political resources. These consequently affect mental health. It might be a good time to take another little break. Can we take another little break?
Yes, this could be a good time for that. Yes.
Okay, so my understanding is, okay, so we can do 10 minutes, maybe come back at we could do maybe a couple minutes more, maybe come back at 11. And then we go for what, another 45 minutes or?
Right, we can go, to about, we're scheduled to 12 o'clock or so, but it might be good to end like at 11:55 or so.
Okay, okay, all right, so I'll see you guys back at 11 o'clock in 12 or 13 minutes.
Okay, thank you so much, Dr. Trivedi.
Thank you. Okay.
Okay, as we're taking a break, you all, thank you everyone for your attention throughout and your comments and staying engaged and interactive. I'd just like to also acknowledge some more sponsors for our virtual event today. So we have some other sponsors at the silver level. You can see that in your brochure. So thank you to Dr. Pat Griffin for being a sponsor for this event, Clinical Psychology Services Incorporated. So of course, everybody knows Dr. Griffin. She's been in the psychology community, and then also in the local community, Arkansas community, for a while. So we appreciate all of her involvement in ARPA over the years. And again, she is our silver sponsor, one of our silver sponsors today, with Clinical Psychology Services Incorporated. Thank you so much, Dr. Griffin, for your support to ARPA. And we also have at the silver sponsorship level is UCA, the Department of Psychology and Counseling. So we thank them for serving as a silver sponsor today. And I think we might have some students on. So we have been in communication with UCA. Thank you, Eric, for including that on the screen there. So, so we've been in communication with them. So I think we have several students, hopefully, that will be coming on later between today and tomorrow from their psychology and counseling department. So we thank both Dr. Griffin and UCA for their sponsorship today. And thank you to Tisha for, including some information that we can search good on Twitter and Facebook for updates and info.
Can you guys hear me? Are we ready? Should we begin or should we?
Yeah, this is a good time to get started. Yes, we can hear you and see you. This is a good time.
Okay, so let me see about sharing my screen.
And as you're doing that, Dr. Trivedi, as people are coming back in, if you don't mind to sign back in just to let us know that you're here. Thank you so much. I see that Cindy has done so. If you could please just put your name in the chat again. That's our way of just taking attendance to make sure folks are still here and with us during this presentation. Thank you. I'm seeing the names coming in. I'm seeing them coming in. Thank you so much.
Okay, so Cindy, I see your question here. I'm a feminist. So I was raised a feminist. Both my parents are feminist. I mean, I use the word feminist. I would say I'm a feminist when it became very unpopular. I know now it's become more popular, but I would say, I mean, I cannot not remember being a feminist. My dad is probably a bigger feminist than my mom. We have my dad and I and my mom, we have like these friendly arguments of who's the most progressive, you know. And so I come from a very unusual background in that sense. So you know, as I mentioned, my dad is a professional engineer. Well, he's an engineer. He's a professional engineer. So he has his degree, his undergrad and master's degree. He's got several degrees, but I won't go into his other careers. But he worked 40 some years. Started out really young as an engineer. And I think I mentioned his degree. A lot of his degrees are in mechanical engineering. But so it's interesting. My mother has just a couple of years of college, and I cannot say. I'm going to say that most of my family is they're not feminist. Most of my family does not. And I tell them directly. I say, you guys do not treat women right. I mean, I would say it's that's very. You're right. It's hard to truly say no for a lot of individuals in India, a lot of women there. So I'm so glad to hear that you did this joint training and you guys were able to address this issue. So is there anything specific? I mean, I'm definitely, I definitely say no a lot. In fact, my father, he gave positive reinforcement when I think he loves telling the story, and the age changes, but I'm always in childhood. The age changes when he tells a story. So I was probably like around 6 or 7, and we went to Walgreens. This is his story. He should be telling this. And I asked for something, and he said no. And he said it in this like dad way that I tell him. It's just, I told him, you know, when we got in the car, he saw that I was upset. He says, "So what's wrong?" I said, "Daddy, you are so mean." And I was only 6 years old. And he was like, "Wow, you're getting your voice." So I'm not typical. In fact, a lot of people will say that even when you're educated, I've seen a lot of educated families have the same mindset. So when they came back from India, when they immigrated from India, it's like they're in this time capsule and time warp, and they're stuck. But it is difficult, yes. I wish I could say I knew more people of Indian descent that are feminist that really tackle on this cultural issue. But you're right. You're right. I don't know if you said anything else. Cindy. I'm trying to look at the other messages. Okay. Have you seen that in Indian or other populations in the U.S. and how do you address it, especially if abuse was occurring? No, that's good. Okay, yes. And how do I address it? I haven't seen any domestic violence or sexual abuse specifically in my work, in my practice. My mother had a friend who I do know, as a teenager, I saw her battered, physically battered, fearing for her life. So it's a good question. I think I would address it in any other population that has domestic violence. So I say it's domestic violence so much, but I see most of the populations are not Indian. So I ask him, I started by asking I get information on the trauma as much as they want to share, and I validate it, and I ask them, I try to help them look at if there's like a family of origin pattern. So I try to do some family systems work. I try to, I ask him, well, first I ask him, are you safe? Where are you staying? Does he know? And if they, where your current address, and if they say or whatever, they say no, I say good, you want to keep that private. I reinforce the things that are keeping them safe. I validate their experience, like, wow, that must be really hard. Just different ways of reflecting it, making sure they have resources. We do actually have a group here in Houston. So we have what's called Houston Area Women's Center, and it's called HAWK for short. Then there's another group called DEA, and DEA in several of the Indian languages, particularly in Sanskrit, which is, quite a few of the languages in India are based in Sanskrit, or come from Sanskrit, means compassion. And so they address domestic violence and sexual assault, trafficking, survivors in the South Asian community. So not just India, but it could be, Bangladesh, Sri Lanka, Pakistan, any of those areas. So I give them those resources. We have a lot of resources here in Houston, and make sure that they're safe. Make sure that if they have a caseworker, their caseworker knows what's going on. There are a lot of legal referrals. So I do a lot of social work, linking into the community as part of the actual therapeutic process. And I follow therapeutic assessment. So I get I use assessment tools just to get an understanding perhaps, but I'm very careful. I don't let, I know that they're not all normed. Very few are normed, or very few I think are culturally sensitive. And so I just use that as one instrument. But I make sure I link them to all the resources here, and just being safe, validating. I hope does that answer your question? Is that enough? Cindy, right? Okay. Is that good, Cindy? Okay, looks like you said yes. Thank you. Okay. So, you don't want to get me started on that, Cindy. Actually, I have a lot to say. Oh, a lot to say. Okay. All right, so now we're at this slide here, slide 16. And let's see if I can minimize this. All right, so I did get a lot of my information. Some things I already knew, but I made sure to get some information, some references to support it. But the majority do believe that socioeconomic status affects their care. I actually have affects the quality of their care, and I actually have some specific quotes that go with each of these themes. So Arpe et al. Identified these 3 themes of patient perceptions: impact on treatment provided, impact on access to care, and impact on patient-provider interaction. So I'm just going to share some of the, I'm going to start with theme 1. So here, my particular, one thing they mentioned was limited coverage for testing. Now, a lot of this really was based on general health, medical health, not so much mental health, but these are some of the themes that I've also found in the mental health community, treatment community. So limited coverage for testing. I experienced that in my testing practice, and my practice is primarily testing with a small amount of therapy if I follow the therapeutic assessment process. So here's some quotes, open quotes. I've had things where the insurance company wouldn't cover, so I have had doctors work around it to still get me what I need. But then there's some doctors that say, well, your insurance company won't cover it, so we can't do it. So end of quotes. So so some doctors or some providers are willing to work around it to get them what they need. So you may have to do more work on the pre-authorization process, or you might have to see if there's some free services in the community. For example, if somebody needs specifically asking for marital therapy or couples therapy, a lot of insurances will cover that. So if you can work in the family systems, you know, I mean, be accurate on how you diagnose. Don't go that far, but you know, make sure that they'll cover it if you bill it under family therapy. That's one thing. There's also like maybe community resources. We have a lot of resources in Houston. So I know this is not really fair to compare what I have here versus what Arkansas or even just Little Rock itself has. But and then, okay, so what they also said regarding this theme 1, open quotes, in those cases, meaning when they don't cover it, in those cases, there may be something that they don't discover because they're not running the proper test, end of quotes. So in my practice, that would be, you know, maybe if I don't use an autism measure, we won't be able to determine if this child has some autism symptoms or if they're really more behavioral symptoms. Are they trauma symptoms? So you have to find some way through resources. It's challenging, I know, but at least I think we should try. The second theme, impact on access to care. Well, I mentioned this earlier in terms of my own particular access to care, and then I mentioned my massage therapist and her lack of access to care. And even people, like if they're both in the Liem, one may have access to care because their income is low enough and one may not. So here in Texas, a mother can get a female can get Medicaid if she had given birth to a child, and I believe it's like for 1 year, but then after that, she doesn't get it. So whenever that gets somebody like that, and I know they have some other medical issues, I encourage them, you know, do it now, you know, do it before this ends, do it in the next 2 months. So when they do have access. Okay, so quotes to go with theme number 2, open quotes. If I had the right insurance, I would have been able to take those tests right away, end of quote. Yes. I mean, and on my own practice, again, it has to do with psychological testing. But as I mentioned earlier, it could be couples therapy versus family therapy. Long wait times that I mentioned, that Federal Qualified Healthcare Center, they're like 400 plus on their wait list. Okay. And then 3 is impact on. Oh, so here's some more quotes. Okay. End of quotes. If I'm on low income, I get the low grade medication, not the stuff that probably could really work. End of quotes. So, you know, I mentioned, well, I don't know, I didn't mention this, but I think Betty mentioned this, that I was in a psychopharmacology program. Actually, I completed it. I completed it technically October 4th. So, so that was like a 3-year long endeavor, but that for those prescribing psychologists, I'm not a prescribing psychologist yet, so I just want to be very clear about that. But for those prescribing psychologists, that could come into effect, or even like individuals who, I had an internist who really felt that the name brand, that Synthroid, has better efficacy than levothyroxine. And I'm not sure where that came from. I didn't ask for the research to back that up. I don't know if he had any financial investment in it. Okay, so theme number 3, impact on patient-provider interaction. So, okay. All right, so this entails provider attitudes towards the patients. So if you go in there, some of the quotes, open quotes, if you go in there and you got lots and lots of money, their attitude towards you is a lot different than if you go there and you're low income, end of quote. Here, also provider knowledge of patient coverage comes in handy. The comments were pretty positive in that providers generally try to make sure they determine what's covered or what's not covered, and they communicate this with patients. Some quotes, open quotes. I don't think the doctors listen to you the same as if you were a paying customer or if you had different insurance. It's like you say something and just kind of skip over it and ignore you, end of quotes. So, this here, and going back to the question asked earlier, how can we work with this population, or how can we better work with this population? Another way is to be aware of these themes and making sure that these are addressed, or that you're conscious of these themes, and that you're conscious of what experiences they may come in, their marginalization. I had a African American LGBT mother come in yesterday, and I not that I don't think the LGBT really matters to what she was saying, but I'm just kind of giving you the whole picture. And she brought in her child for evaluation, and they're involved in this is a CPS case, and the mom was very irritated with the questions I was asking. And I told her, I said, these are standard questions that I asked them of everyone. And she felt they were so irrelevant or intrusive. And they were just just going over psychosocial history, family background, where the child was born, any medical conditions, any substance use history. And I honestly asked the same question of everybody that comes in, even the few occasionally higher income people I have come in. But she made a comment. Her comment was, I'm going to paraphrase the essence, give you the essence of what she said, that they think our African American kids have all these behavior issues. So I'm not comfortable with all these questions you're asking. And I did ask her questions about how's he doing in school. She says, fine. I said, have the teachers given you any reports? And she said, no, they say nothing. He's not doing anything wrong. I said, well, how does he manage his temper? So just everything going through, because he's coming to me for evaluation, and the mom wants the evaluation. So I'm asking these questions, and when she said that, I just sat with that, and on my head, one thing I'm thinking defensively. Well, but I ask these questions of everyone. I got to get these questions. I need to know. I mean, obviously, if you're bringing him in here to me, and these are all things I'm having, conversations I'm having in here. There's something I need to know, and so I sat with that, and I validated her experience and acknowledged it. So in that instance, I probably adjust theme 3, impact on patient-provider interaction. Okay, some questions in chat. Medicaid oxygen limits its number of Medicaid patients prescribed. That is very, very, very disturbing Teresa or Teresa? Teresa. You know what? I don't know if there's the same thing in Texas. People choose not to get their psych meds. Well, you know, we have in Houston, we do have, yeah, I think we have more safety nets here. If, you know, if you're limited in what medications, like if you had somebody had this kind of limitation. I'm curious, in Arkansas, can adults with that don't have children who are just poor, can they get Medicaid or no? In Texas, if you're a single poor adult, you don't get Medicaid. Like, you know, like my massage therapist, you know, she's got a lot of medical issues, so she can't. Okay. Yes, if they make money. Okay, that's good. That you're ahead of us. You're ahead of Texas in that aspect for sure. And probably many other areas. If you're on disability, you can. Okay, very low income is eligible. So yes, in Texas, if you're on disability, you can get Medicaid. But if you're not on disability and you're just struggling to make ends meet, and you're just not making enough money. I mean, the salaries have gone up here, even for like service, you know, food service. You can get at least $15 an hour is the now going rate. They just jumped over that minimum wage. But then the thing is, everything has gone up. So you're kind of like back to where you were. I mean, everything. I get a coffee, it's a whole dollar more. I can afford that whole dollar, right? But I mean, everything. Groceries have gone up astronomically. Okay, so we got those themes there addressed. Okay, working with them. I'm sorry, I don't know if you can see me. It's my first time doing, as I mentioned, my first time doing this type of presentation virtually, so I'm going.
So I thank you for your patience. Okay, so working with the Liem. Again, going back to answering the question, how do we work with this population? So our practice must be responsive to cultural and social contexts of racial and ethnic minorities. The DSM has a chapter called Cultural Formulation Chapter, and in that they have an outline for cultural formulation. They talk about cultural identity, cultural conceptualization of distress, psychosocial stressors, and cultural features of vulnerability and resilience. Wow, that's a long one there. So let's talk about this. So this kind of goes back to, forget who asked, somebody asked me about the culture in India and the difficulty of saying no. I'm looking back, who told me that? Okay, Cindy, okay, Cindy. So, okay. So let's talk about that. Let's use that. What are the cultural features of vulnerability there? Anybody? Cindy? Anybody?
I would like you to repeat the question because I couldn't quite hear it.
What are the cultural features of vulnerability? It's also on my PowerPoint, cultural features of vulnerability. What do you guys think that is? So with the population that Cindy talked about in India, you did that sex trafficking workshop, being able to truly say no. So that's one thing.
I know what the people in India told me specifically when we had more conversations about it. It's that even because culturally, for most people in India, I won't say all, to say no means you're not agreeing with the group. And because of the collectivistic nature, even though there's the hierarchical nature of society in India, it's also very collectivistic. Who do you belong to, and do you cause shame to anyone? So saying no can communicate this sense of shame. And so being vulnerable to go against, it's vulnerable for you to go against that. And in that context, so it was really interesting for me to see when we were having our international group meeting, where we had Indian leaders who are still who teach these girls to say no to protect themselves, and they have to say no in different kind of contexts now that they're not used to. They had difficulties being vulnerable about talking about that with a group that they knew they were mostly safe with, because we weren't going to judge them because they struggled with it. We just were trying to understand their experiences better, because like in my context, when I am serving in a safe house sometimes in Finland, I'm working with women from this area of the world, and we see some of these things play out. So it became just going against their culture, and in some small way makes them vulnerable. And then to have to admit that to some people who are probably applauding them for going against the culture if it kept girls safe, to see them hesitate was very powerful to me, because that's how hard it is when you think about when you're sitting with someone with a different culture and you're like pushing them in a way that maybe they're not ready to go. There's so many more layers. So it's very vulnerable then for them to even open that part of it up. And maybe they don't even have the words to explain why it is the way it is. That's kind of how it hit me.
Thank you for sharing that. So we have just, I mean, we as a culture, as an American culture, or the country itself, in some ways we are, or as psychologists, maybe it's even our training or the qualities of our qualities that led to our training, we are at such we have so many more options and so many more safety features. I mean, I don't want to minimize that we have the same issue here too, but you know, in a different way. It's something that I do struggle with as someone of Indian descent. And in many ways, I'm still very collective. I'm very collective, and in ways like, I mean, I do look after my parents, and you know, I try to think of the group setting, what's good for the group, but I also say no if I don't want to go with the grain of the group. But not everybody has. It is difficult, and the resilience, you know, any cultural features of resilience that either you, Cindy, or anybody else have experienced, what would you say are cultural features of resilience? What does resilience mean clinically to you guys? Somebody answered here. Ability to thrive and do well despite adversity. Okay. So thank you, Dr. Holmes. Ability to bounce back despite whatever is thrown at you. Where do people get this from, this ability from? Cultural factors connected to family, community, and faith can help, yes. So let me just kind of racial identity for those the best they can with the resources, however limited they have. Okay, so let me just tell you about my dad. My dad is like, we argue, we're very, people say I'm his little mini me, just shorter and female, but also obviously look different as a female. So my dad is the firstborn of 5, and he actually grew up in a coal mining town in India. And he was, I'm talking poor. I'm talking very poor. Electricity, you know, they had a plug that so he could study at night, right? So he had a plug put to, they connected their plug. They got electricity by connecting a plug, borrowing an outlet from one of the neighbors, and paid the neighbors some money. But his resiliency, I mean, how does somebody like him, I mean, parents are not really that well educated. He's very poor, but he perseveres. Nobody has to tell him to do his work. Nobody has to tell him to go to school. I mean, he does it. And people describe him as like this light in this coal mine town. It makes me think of coal miner's daughter, but it's different. But it's a very, I mean, there is a coal mine community culture there. But his resiliency was that his mother kept him in school. So he had that support. I mean, he had that drive, but his parents could have taken him out of school. What's he going to do as a child? So his father wanted to pull him out of school so he could get a job and help support the family. And his mom said, no, I'm going to keep him in there. So she saw something. She saw like, okay, this is a way hopefully out of poverty. So that, and then, you know, my dad got support from other people, you know, like they would say things, you know, like, oh, you're such a good student, you know, keep it up. And, you know, we're proud of you. So that was his resiliency. You know, my spirituality in the church, yes. Within the African American community, yes. Family, spirituality, I see that a lot. I think it's amazing. I started this documentary. It's on Amazon, PBS, done by Skip Gates. Well, there's an Amazon documentary, and it talks, well, it's kind of a challenging, it's not just looking at spirituality in the church for the African American community, but it also kind of challenges that, and how, while there's so much still poverty among African Americans, and still many psychosocial issues. And so I haven't finished that documentary, but it's on Amazon and Amazon Prime. So it could be their support system, it could be the family, one person in the family, can even be rituals. And rituals, you know, they could be like found in the church, or it could be, you know, like a connection, something that you do with a certain person. Okay, so the DSM, this chapter also addresses cultural features of the relationship between the patient and the clinician. So this is something that we really need to think about. So let's take a few minutes. What does this mean for you guys? The relationship, the cultural features of the relationship between you. This is another thing that's very important in being able to work with this population and be successful. So take a minute just to think about this. One thing I do is I try to find ways, when people come in, and I start off with the evaluation, psychiatric assessment, you know, I ask them, so what part of Houston, you know, I find out they were raised here. What part of Houston are you from? And they'll tell me, oh, North Houston. And I'll say, oh yeah, what high school? And then sometimes I'll say, oh, that's the same high school I went to. Just don't ask me what year. So you're not old enough to ask me what year. And so I try to find ways to bridge the gap, consider the cultural issues with authority. Absolutely. Absolutely. because maybe they consider us an authority. Certainly, I think they start off that way when they come in, because a lot of times they're required by CPS to have this evaluation with me. Human respect is a common denominator. Yes. Yes. And we don't want to make assumptions too. I mean, a lot of people make assumptions that they're so shocked when they find out I'm a feminist, and they find out that my parents are feminists. They're very shocked. And I don't really practice Hindu. So Hinduism is very interesting. You can practice it and not practice it in a ritual sense, and not really in the temple, or we call mandirs, mandirs, but it's people make a lot of assumptions. So yes, human respect, consider their issues, the historical issues and current issues with authority. Okay, and also DSM talks about overall cultural assessment. And that's where I think a psychosocial following a psychosocial format, addressing all these things. Even though my African American mom that came in, was upset at being asked these questions. I think, still it's important to know, what is the history, if any, with legal or behaviors, background. I go into detail and I try to get as much as I can. So how did your mom and dad meet? And a lot of times they look at me like surprised, like never really thought of that, and I guess maybe that's more of an individualistic culture. You don't think, okay, that's their relationship, it's not our relationship. But okay, so here we are. We're still working with the Liem. Okay, so again, DSM, a good resource. Cultural formation interview. There's two versions. There's the interview version, and there's the interviewer version and the informant version. And there's some differences here. We have cultural definition of the problem. So you got to ask them, is it a problem? Don't assume because they come from a traditional family, and they're saying, and let's say a collectivist family, like a traditional Indian family. Don't assume that that's necessarily the problem. Find out what the problem is for them. Is it a problem? And I ask them, so how is that for you? Is that positive or negative for you? Positive, negative, or neutral? So I try not to give any leading questions, just how is that for you? So how can I help you? How can I help you? Is there anything I can do for you? I have a provider that asked me that question, and I think it just really inspired me to say that more often. I already was saying that, but what can I do for you? So what do we want to work on? Are you ready to quit drugs? Is that something you're ready for? What does it do for you? Cultural perceptions of the cause, context, and support. This goes to resiliency, causes, stressors, supports, and the role of cultural identity. Cultural factors affecting self-coping and the past help seeking coping. What were the barriers? Have they received help in the past? Why not? How was that for them? Why did they terminate after 2 sessions? Cultural factors affecting current help seeking. What are their preferences? Clinician-patient relationship. I don't have a preference. I'm not sure why. A lot of times I ask, do you have a preference for this type of provider? Or I have to, many times for me, I guess medically, it doesn't matter to me, but there are people, I would prefer somebody that speaks Gujarati, which is my first language actually is Gujarati. My second would probably be Hindi. And then my third might be, and I'm thinking, because I'm living in Mumbai, when you're living in India, there's always multiple languages going around. So I'm hearing all these things. And if you're in Mumbai, the dominant, well, Marathi is one of the dominant languages, but Hindi is the official language, and Gujarati is my regional language. So I'm hearing all of these. And my mother was saying that when I was talking to my babysitter, and this was in the US, I went to an Indian babysitter. She spoke Hindi to me, and I responded because she was not Gujarati. She was actually Punjabi, but she spoke Hindi with me. And she said, you would actually have conversations with her. You talk to her in Hindi, and then you talk to us in Gujarati, and you talk to other people in English. But so you want to find out what their perception is. And when I say interviewer, you are interviewing the actual client, the actual patient, the individual that you're seeking to serve. Look at the cultural factors affecting self-coping, okay, and past help. Mentioned this already. Cultural factors affecting current help seeking. Okay, this is what I already mentioned. So do they have a preference? Do they want somebody of color? Do they want somebody who's African American or white or Hispanic or Nigerian? Then there's a culture formation interview. You may or may not always get this. This is if they have an informant. And sometimes if they have a support system, the support system may be somebody from there may be a good informant. And you want to explore their relationship with the patient, their definition of the problem. So this comes from the informant. Cultural perceptions of cause, context, and support. Causes, stressors, support, cultural identity role. Cultural factors affecting self-coping and past help. So you're getting this information from the informant again. Could be like a family member, fictive kin, a friend, community member. Cultural factors affecting current help-seeking preference, clinician-patient relationships. So some of these overlap with each other. Okay. Again, how to work with this population. Need more innovative, comprehensive treatment. We have to address the psychosocial needs and support the fact that these families are experiencing poverty, that the individuals experiencing poverty. So innovative, comprehensive treatment, address their psychosocial issues, names of food banks, or where they can get domestic, we have domestic violence services that offer housing and employment training. Work in the natural environment if you can. If you can't, I mean, and this refers to like home-based, school-based, community-based. I've actually had sessions. I saw this one child at his home, but he was very embarrassed of his home. They had no running water. This is in Houston. No running water. I could not believe this. No electricity. They didn't even have a floor. I think they had that subfloor that you put on before you put on the regular floor. And he was very embarrassed. And he told me, we're not, his grandparents were raising him, and they said, we're not really, our house is not really suitable for us. So we sat on the porch in the heat in Houston. And that's where we had our session. So, but not everybody can do this, not everybody wants to do this. So I don't go out into the community anymore. I did several years of it, and that's not something I'm willing to do, but I will go out and I will do like talks, pro bono talks, or, I'll just go out and I'll experience the community, go to the restaurants, or, drive through, or ask him, what's it like living there now? Or what's that like? So sometimes I get the experience through them vicariously. Use evidence-based treatment. Okay, so this ties in with the comprehensive treatment. Everything you want to use, I mean, not everything, but use as much as you can. CBT, trauma-focused CBT, DBT. So use as much of that as you can, but you're going to have to tailor it to the individual's cultural background. Capitalize on their strengths and resiliency. So capitalizing on their strengths, when I do this, it's, I try to find out, what are you really good at? What do you think you want to do with your career when you go back to school? Now I'll point out, you have a really good way of expressing yourself, and how could you use that to work on your relationships and resiliency, as we mentioned earlier. Okay, so when I talked at APA, they asked me to talk about developing a private practice with the Liem. That's how I sustain my living. I didn't start out, I didn't just set up shop, said, okay, here's my peanuts clipboard, the doctor is saying. It took a while. It is actually possible to sustain a living. You can have a living. I started with a business plan, and there are different business plans out there. There's so many components to business plan, but I put down my objective, my mission statement, and my goals, and marketing. Like, how am I going to market? I started very small, but I had a vision of how big I wanted this practice to be. I'm still a solo practitioner. I have one employee, and that person handles everything else, the billing. I started out working for somebody and doing this part-time. Cultural factors affecting current help seeking preference, again, clinician-patient relationship, your own comfort level. I have kind of a service niche. It's not a very high income service niche. They're all Liem. And I'm very comfortable though. I'm very comfortable with this population. Limit your overhead. So yeah, okay, you could rent hourly, get a small office, work with a group of people, share the office space. I actually started out doing home-based work and got a feel for how to bill on my own. And then I rented hourly, and then I had a small, single, tiny little office for the longest time. And now I have 3 offices and a waiting room. And I have that much. One is for my employee. The other obviously is a waiting room. And the third is it houses all my testing material. I've got probably way too much testing material, and it's another testing room. So, okay, network, pro bono speaking. I've given a lot of really low, a lot of talks for a lot of the referrals. And so that I kind of work into, that's how you're getting paid and you're networking, but this is the referral source. So for the referral source, I do a lot of pro bono speaking, but you can do it even without. And it's something you can deduct. Creation of office space. Okay, your style, values, layout. Okay, let me tell you something. My culture, Indian culture, and I like to say the Southerners, I think I'm also Southern in this aspect, but we like to feed you. So I have food here for people. I have some hot food. I have oatmeal. At some point when I get a kitchenette, I'll have other things too. But tea, coffee, drinks, crackers. So I send this off with people, when I know they're homeless. Just give them bottles of water, like take this, and they're going on the bus, and you're going to be on the bus a long time, you need something to eat. So that's my value. And I like to have, as you can see flowers. I like to have flowers. I like it to look nice. My office should be, I feel like, I don't care how much money you make or you don't make, you're going to be treated like royalty here. I mean, that's just, that's my value. I'm going to treat you like you come to my house. I mean, I'm not going to invite you to my house. But, I got to have certain boundaries. Okay. But this is our space when you come in. And even when I'm trying to change another test, I'll ask them, can I borrow your chair? And one person, this is your chair. I said, well, no, right now it's your chair. So, make it fun. Do much of what work yourself as possible, comfortable. I mean, I did my own website, billing. all these things until I made enough money to hire somebody, and I was just so burned out with Billy. So, okay, so inside my practice, all right, again, this is what I shared with at the APA. It is possible to do this. And I make as much now as I make. If I didn't have to pay the arm and a leg for insurance, I would say I make more than when I work for somebody else, and I work less. So, but it took a while to get there. I first became a Medicare provider, and you have to in order to accept Medicaid. And then, I balanced between diversification. And first I started off with, working for somebody else. And so I had a steady income there. And then, I built up these different, income streams. I have a contract with DFPS. So I see a lot of CPS individuals. I focus on customer service. So eventually when I felt secure enough, I'm like, okay, you know what? We're going to jump ship now. We're going to do this on our own. And there are months when it's slow and the referrals are slow, and there are months when it just pours. And so that has probably been the biggest challenge for me. Still gotta pay my bills. So, okay, so getting towards the end. So, again, this is just some pics of my practice. You see that building there? I'm on the count each glass. I'm the 6th glass. I'm talking to you from that 6th floor right now. And that corner. Yep, that's me. This is a view. The second picture is a view of my office. The south side where the freeway is. No, sorry, the north side where the freeway is. So there's a freeway. And I'm looking down from the 6th floor. Okay, so that's my office waiting room. You see, I like flowers. Office waiting room. Second picture is actually of my office where I'm talking to you right now. And that window is where the pictures came from of the freeway. This is my testing room. This is just a small picture. I mean, you can see I've got lots of testing material. And then this one is for my employee. And sometimes we use it over, we have overspill. We have so many people testing. So, okay, you can sit there. Okay, last picture. Find ways to bring joy into your practice. It can be anything. It can be, your decor. You want a special seat or chair. You want to be able to work with a certain population, or you want to learn this new skill, or read. I'm going to go read about the Marshallese tonight. I don't know about you guys, what you guys are going to do today, but that's what I'm going to do. So there we have Chino, my little baby. He turned 3 years old this last Sunday, and he is yawning in the second picture. And you can see he is asleep at the job. And that chair is right across from where I'm sitting. It's asleep at the job. So that means it's time for a nap. And so let's end this with thoughts and questions. You have the reference list there. Here's my contact information. And if you're ever in Houston, please look me up. I'm going to make sure you experience our Southern hospitality here. Okay, any thoughts or questions? Thank you so much. Oh, yeah, I thought I'd add the little awe factor. Yeah, thank you. Thank you for being so patient. I don't even know how this is going to turn out on YouTube, because I'm looking this way at this computer and I'm turning this way. But I thank you for listening to me. Any questions? Any feedback? What did you not get? What do you need now? Tell me what you need now. What do you still need? And you can always reach out to me by email too, but what do you need now? There's something you're expecting from the presentation that you didn't get, or you want some elaboration on. No? Now, there's room for improvement for me in the presentation, and I would like to hear that. Yes, you know, they have a website. Yes, yes. Doctors for Change. Yeah, you could Google them and see what format they follow. They have two different divisions. One is for mental health and one is for human trafficking.
Well, I'm seeing in the chat, Dr. Trivedi, this is Dr. Holmes. I'm seeing in the chat, just people are saying, thank you. Great information, great job. It was very helpful and great information. So I know what I'm going to do on my end when it's uploaded to YouTube. That gives us a chance to go back and continue to digest all of this great information that you provided. So thank you for that and for your time today. Yeah, people are saying thanks so much. Great job doing this virtually.
Oh, thank you. Yes, thank you guys. And you know, it takes both of us. I mean, you got to handle the or whatever the little nuances we have, moving back or the freezing. So, but isn't this wonderful that we have this so we can reach out to each other? You know, this is another way you can, I have sessions with the Liem, you know, they're on their phone and they're at home. And so we have, and I do it by Zoom or FaceTime, and still it's such a great tool. Thank you so much.
Dr. Holmes and Eric Duray, if people want a copy of the PowerPoint
who are presenting with sexual issues. Sometimes these will be individuals. However, you'll work with troubled couples. Almost all of them are having difficulties in the sexual realm. While some couples will openly complain about the sexual difficulties they are having, Dr. Wakefield reminds us that if we don't ask about this, it sends a subtle message that talking about sexual issues is not welcomed. Dr. Wakefield is also aware that very few clinicians get sufficient training in how to deal with sexual issues, which is why she's providing this topic. Each week we'll cover a different topic, such as the necessary personal work required to be an effective sex therapist, how to open the conversation and create a safe space for people to talk about their intimate concerns. She'll also focus on assessment and case conceptualization, creating an individualized treatment plan and the importance of working at the right level, helping partners talk to one another, and also helpful intervention for specific sexual dysfunction and partner dissatisfactions. She's one of the only certified sex therapists in Arkansas, and she'd like to see that change. So again, she's beginning to offer education and supervising therapists who are interested in pursuing a sex therapy certification. And this certification is through the American Association of Sexuality Educators, Counselors, and Therapists. And they are the long-standing certifying body that holds a particular standard for education and have a strict code of ethics. So again, if you want to register for this course on essentials of sex therapy, you can search for the title of the class at UAMS, or you can go to the Couples Center website and you can find it there. As we're transitioning to the 1 o'clock, I'm just going to go ahead and put the Couples Center website in the chat. So if you want to look into this course for Essentials of Sex Therapy, you can do that. And again, we thank Dr. Wakefield for her sponsorship. If you're just coming on, please put your name in the chat. We're taking attendance. Please put your name in the chat. And I'm going to go ahead and turn it over to our president, Dr. Betty Everett, for this continuation of Dr. Trivedi's presentation. All right, thank you, Dr. Everett.
Eric, can you get my video back? Awesome. Thank you. Hello, everyone, and thank you for being here today. I enjoyed the morning presentation from Dr. Trivedi. In the next little bit, I'm just going to talk a little bit about the Presidential Task Force on Liem and some of the differential effects that we can see. I believe that Eric will be putting up a PowerPoint for me. Is that correct, Eric? Eric?
I didn't realize I was doing that. I'm sorry. You may have asked that.
I did ask that. Do you want me to run grab it, or?
Yeah, that would be good because there's too many things going on, unfortunately, for me.
All right, let's see if I can get that. Y'all, I'm not a good,
And Betty, if you want to forward it to me, if it's easy for you just to forward it to me, and I can share it on my end if I need to.
okay, that sounds good.
Okay.
Okay. Done. Okay, let's see here.
I got it.
And I've got it up too. So,
Oh, excellent. You have
yeah.
it. Excellent.
All right, great. So I just want to say thank you to, is that showing for y'all? Yes.
Yes, it is.
All right. Thank you for folks who have participated in the task force. Dr. Pritchard has been engaged and has agreed to continue this task force next year. So I'm very happy about that. Dr. May has been involved and I believe will continue her involvement. Dr. Lee has been helpful. Dr. Zelensky, Dr. Griffin has been very actively engaged, and I'll tell you about some of the activities she's helped us with. Dr. Jordan, Pam Thurman. Dr. Thurman is a Native American, actually a personal friend of mine. She and I went to Oklahoma State, the clinical psych program together, and we've been happy to have her involvement. Sylvia Fernandez is a local mental health provider, very connected with the Hispanic community, and Paul Chapman is the director for Restore Hope. Paul, are you with us? I know he was here for part of the morning. I'm not sure that he's here right now. So what we've done to update you since the spring conference is we've continued monthly meetings. Dr. Griffin and I did a podcast facilitated through Restore Hope for a private entrepreneurial company, Empower My Environment. And we talked about trauma, symptoms and treatment and ACEs and PACEs. And I think that was very well received. That podcast is available on Facebook through Restore Hope. I presented on trauma-informed care for Restore Hope case managers, and I also did a presentation on PACEs for them. And I'll share with you a little bit of data about that in a moment. And then we're going to talk some about some ideas for psychology involvement and have time for questions or comments from y'all. All right. So for those of you who do not know, Restore Hope is was initially started a task force from the governor's office because we were having so many people incarcerated. We were at a point where we might need to build more prisons in Arkansas. And he said, I don't want to build prisons. I want to help people. And so the mission for Restore Hope Arkansas is to decrease the amount of children placed in foster care and to decrease rates of incarceration through collaborative partnerships within the communities. They do that utilizing a crisis to career model and collaborative case management, 100 families, and effective partnerships with agencies, businesses, police department, juvenile justice, anyone who might be involved in some way that can be helpful with that. Part of their success, they started in the Fort Smith areas. In 2 years, the number of children in foster care decreased 32%. The inmate population decreased 19% in that county. These efforts are impacting the entire community. In 2019, they had direct contact with over 3,000 lives. So we have partnered some with this program because they serve low-income families, and in particular low-income families who have problems with incarceration. Just to share a story with you about one of their initiatives. When someone who is stopped by the police and don't have a license, they get a ticket for not having a license. And that starts a court record or potential incarceration process for them, because the penalties can keep increasing and then the amount that they need to pay can keep going up. And so in Fort Smith, the local police and the justice system and people said, let's change this. Let's give them an opportunity to get some treatment and some help in lieu of a fine. And so they have a choice to do that. And if they do, then they get some help and they don't wind up even going into the juvenile system at that point. So in the PACES presentation, I asked the case managers to fill out their own ACEs, and we'll talk about that data in a minute. Sarah Littleton, who is with Restore Hope, was very helpful in helping us get that information. I also just want to say that there were some non-psychologists and other folks involved on the task force. Helen Porter and Donna Malone have been helpful as well. So we also wanted to begin to make some recommendations for psychology and how we at ARCPA might be able to provide some help for these services. Restore Hope is working on a process, if they get the funding, where a mental health provider can see someone through their agency and bill Medicare, Medicaid through that agency, so that if as a psychologist or provider yourself, you don't take those insurance, you might do it through them. You could get paid for that service, or you could do it pro bono, whichever felt right to you. And it would be going to their site, which they're working on a clinic in south part of southwest section of Little Rock. So that's just the idea of donating services. I'm going to look more into that, doctors who want to help, that we heard about this morning. Another important area that we can work on and interface is public education on the impact of poverty. You know, we have a public education committee, and Dr. May, I think, will start. We've had a little bit of problem with that, but we've got it straightened out. Not her fault. And start talking about the impact of poverty and the differential factors that we see related to a history of trauma, racial discrimination, and other issues that are involved. Another way I think we can be very helpful and potentially give to our community is to provide social skills training or educational programming. And we could do this via televideo. One of the ideas that had been discussed, I think, a few years ago when Dr. Phillips came, was maybe some sort of partnering with the library system, because a lot of these folks don't necessarily have internet connection or what they need to do televideo. But I personally had folks who don't have internet connection go to sit in the parking lot of the public library to get connected on their phones. And, you know, we have a very active government relations committee, and anything that we can do to help and continue to influence public policy and awareness on this. We'll get some more information from those folks in that committee this afternoon, and I'm excited to hear what they have to say. So I want to take a break for a moment and see if y'all have any thoughts about those suggestions or any ideas yourself. And I'm going to see if I can see the chat, but you should be able to unmute and talk to me as well. Hello? Dr. Griffin, would you like to add anything? Are you back with us?
Yes, I'm here, Dr. Everett, and thank you for the opportunity to share a few comments. As Dr. Everett mentioned earlier, we presented to a group via Zoom on adverse childhood experiences. And we were even able to connect with someone in Paris who was a part of that group. So we had an international presence. And believe it or not, the sound quality was very, very good. The group was very responsive to the information that we shared. It was very interactive. It seems like they were relieved to know that some of their lived experiences have been researched and explained through the psychological literature and other research that's been done. They were empowered, I would say, to move back in the community, to give back to individuals who have been recently released from incarceration. And I was just amazed at the interaction, the receptivity. And Paul, what is Paul's last name, Betty? It's a Chapman.
Chapman.
Yes, and I regret that he's not here.
I'm
but
here.
Paul, oh, okay, Paul, glad you're back. Paul has done great work with this group, and I think there is a lot of potential for psychologists to be more involved, working around their schedule. And Paul, you can address this in more detail. It will require some flexibility. We may not be able to, those who are interested in this initiative may not be able to provide services within the traditional Monday through Friday 9 to 5 model. And Paul, it would probably be helpful if you can just share some information about that. But this was an outreach to a community-based group that Paul has been working with to reintegrate back to the community, providing skills for employment, and just a myriad of opportunities available, basic skill training, psychological issues, you name it. If you have a topic of interest that you would like to present, Paul can make that connection.
Yeah, and Pat, that made me remember that the work that Restore Hope is doing with people getting trained for truck driving, he was very helpful in interfacing with Pam Thurman, who has very strong connections with the Native American communities. She's Cherokee, and I know did some reaching out to help some of those communities after conversations with Paul. Paul, would you be willing to just talk a minute about what y'all have planned at Restore Hope?
Sure. You know, I was in a grant making and a direct service function for many years. And so it gave us a perspective to see that, you know, the individuals that we target who are typically justice involved or are about to be, are in complex situations. And so our clients typically are in 3 years crisis in kind of the social determinants of health when we meet them. And if you're you know, read in these areas, there are all kinds of white papers showing evidence for interventions. The problem is that usually you don't stack those, or it's very difficult, exceedingly hard, to be able to put all those things together in the way that it's needed. And one of them would even be, you know, one size doesn't fit all. So everyone needs an individualized plan. And so what we've been able to do, really through the goodness of many Arkansans and the governor's support and many of the agencies and foundations, is we have a software system that's a collaborative case management system that's HIPAA, FERPA, and COPA compliant, that allows a community to actually build a care team online from very diverse groups that are all needed by that client in what we kind of think of as the journey from crisis to career. And that journey for some is 6 months, and we've had clients, 3 years, and they're still in the journey. In fact, we're at the point now where we're hiring former clients, training them as case managers and placing them in the model in a point of contact, a jail, a child welfare office, parole probation, shelters, that kind of thing. So anyway, it's the big idea is that to really have better outcomes, the next step for Arkansas is truly a coordinated care approach across organizations. So I bet many of you work for larger organizations that have some, kind of strategies to be able to get all the different people in your org to work together at the right time. This is no different than that, other than the people on the care team work for different organizations. Outcomes are quite impressive. And maybe even more importantly, in the justice space, no one's mad at us. Everyone's happy. Law enforcement likes it, judges like it, nonprofits like it, therapists like it, because no shows are down and folks are motivated when they're coming to them. So that's good. I'll leave you lastly with one of the most surprising outcomes is in Arkansas. If your children are taken into foster care, you're probably not going to get them back. Only 42% of the time do children reunify with their family, but by using this model, Fort Smith, for going on 3 years now, is above 80% reunification rates, and now 3 additional counties that have all launched in the last 12 months are all above 70%. So it's just coordinating care, and it's good for the clients, it's good for the taxpayer, it's good for the providers.
Thank you. So I've pulled up the wrong PowerPoint to show you this data, but in one of the presentations for the case manager staff at Restore Hope, there were about 10 of their case managers there, and 10 case managers cover about 100 families. Is that correct, Paul?
Each case manager, depending, they'll have somewhere between 50 and 80 clients apiece.
Okay, so that's a lot of people, but we wanted to start kind of awareness of the ACEs and the impact that can have on health, physical health and mental health. And so they all agreed to take the ACEs themselves. And when we looked at the data from the case managers, those of you who are familiar with the ACEs will recognize some of these questions. I wanted to just share with you kind of the top positive responses we got for adverse events. And the highest 2 were your parents separated or divorced, and 75% of those case managers grew up in a home where the parents were separated or divorced. And then another question was, did you often feel that no one in your family loved you or thought you were important or special, or your family didn't look to each other, feel close to each other, or support each other? And that was a 75% positive response on that one too. So your caseworkers also had a significant history of growing up in a household where there was history of mental illness and depression or suicide attempts, and that was at 67% for those case managers. So what you really have is case managers who are really kind of peers who understand and have had their own ACEs history, that part of how they're dealing with it is to help other people get out of those cycles of poverty and trauma. And I just think y'all are doing great work. And I think as psychologists, we can continue to have an impact in these areas. So I'm gonna leave it open now for, again, questions or comments from any of you in the group. And, Paul or Pat or I are certainly happy to keep talking if we need to do that. Anyone have any particular thoughts or questions that you'd like to ask about? Dr. Trivedi, you're here again, is that correct?
Yes, yes.
As you listen to what we're doing in Arkansas and that presidential task force, do you have any thoughts?
Well, no, what is the RA stand for?
Restore Hope, the program that Paul was
Oh.
talking about.
So these psychologists can see patients like, through their agency. Well, so my thought is that, are they just now getting that ability to do that, psychologists?
A lot of psychologists in private practice do not take Medicare or Medicaid because of the number one, the restrictions that you have to have in terms of being approved and the level of demands from those systems and not great payment. I don't have a recent survey of local providers who do take Medicaid but Medicare, but historically, a lot of psychologists don't necessarily provide services for those populations who have that insurance.
Betty, we do have a number of psychologists, however, who provide services to the Medicare population through their practices. And this would not preclude billing through their individual practice. Billing through Restore Hope would be an option for those who don't see patients in their practices.
Right. So if I were still at the med center and only saw patients through that format, then I might donate some afternoons or evenings to see patients through the Restore Hope. So Paul, we have a question. Is there a Restore Hope program in Pulaski County?
Yes, it's our newest county. We just launched, and we currently we're managing care for 100 and just over 100 clients, and are going to make an announcement probably in a month or so, along with the sheriff and probation on a new program here. I will tell you in Pulaski County specifically, we've number of children so we've got a lot of violence, like many other places, but there are things that are going on that have impacted our child welfare system, and we've had about 100% replacement the last 9 months of staff and DCFS, which is affecting quality of care. We've got over 700 kids in care in Pulaski County, and we're kind of mobilizing some help to try to help DCFS kind of move back in, take that back over. But yes, that was a very long answer to a short question. Yep, we're in Pulaski County. I would say, on the connection to therapists, we refer, almost every one of our clients is required, depending on their court case supervision requirements, wherever we meet them at a point of contact, to obtain substance abuse and or mental health treatment. So we make a lot of connections with licensed therapists in Arkansas. Some agencies they're just hiring. We refer so much that they're just hiring new staff that just serve the program.
That's great.
Sorry, I got kicked out as you were talking.
Oh.
Sorry.
Okay. So Paul, the 4 counties in Arkansas that you serve are?
In Western Arkansas, we started in Fort Smith, and we did that in 2016 based upon just need. They had 800 kids in foster care. That was 1 in 34 kids in the county were in foster care at that time. So we're in the Fort Smith area. That's Sebastian. Just north of it, across the river, is Van Buren and Alma. That's Crawford County. Then we launched in White County, which is, kind of north and east. It's Searcy. And our newest county is Pulaski. We are seeking funding to expand over the years to help a number of other, the big population centers launch their own efforts and support them in it. But some folks in Russellville and Texarkana they just said, we don't want to wait on you. Can we try it? And they're going to self-fund the launch. So
Right.
a group in Texarkana, a group in Russellville are they're using our system. We're giving them our models. Now we're bringing the lawyers in, which will probably kill the whole thing, to figure out, liability and affiliate and all that good stuff. But that's where we are. We hope, really our desire is that at least for the population that have, complex crises going on, that we can network the state. It's small enough that we could get that done, in the next 3 to 7 years, I think.
Great. So I have a couple of questions here. One is from Carrie Crawford. How can mental health professionals volunteer to help? And are there things that undergraduate students are pursuing a degree in psychology might do? So you can certainly let Paul at Restore Hope know if you want to get involved and volunteer. You can kind of do your own initiative in your local area to, do some sort of presentation that helps with public education or skills training. We've talked about with Paul the possibility of having graduate students help us give, for instance, the ACEs to all of their population that they serve, and the graduate students could then help them kind of score and understand the meaning of that. Pat, as kind of an active part of the committee, would you add anything else to that?
I think those are great opportunities, not only for our students, but also for academicians who work with students who may be interested in working with this population. If we could have your contact information, Paul, if you could put that in the chat, then we will know how to get in contact with you directly for this group, for our association members who may be interested in working with you more closely. If you could just provide your contact information, I assume that we can just call you or email you directly. Is that correct?
Yes, ma'am.
Thank you.
Something flew in my head and flew out, so it's probably not going to come back. We have gathered a fair amount of educational material. If this is from Sally, I will make a note to send you some if you want that. Anyone who needs information can certainly contact me as the chair, or Dr. Pritchard as he starts next year. All right, I think we have gone to 1:30. It's been great to present and let y'all know about this, and I appreciate everyone's help. And thank you, Paul and Pat, for joining in too.
Thank you, Betty.
Mm-hmm.
Thanks, Betty.
All right, thank you so much, Dr. Everett. That's just great information that you all provided. And I'm so glad that Paul Chapman was able to join us again. I know he's been at a previous time of ours. Hi, yeah, it's good to see your face again. So thank you all for that content and information. Well, we're just going to take just a couple of minutes to